the Brazilian Association of Health Insurance Companies. Good morning, everyone. We are now beginning this debate promoted by FIS and Abramge. Today, we will discuss increasing access to health services. I wanted to give you a brief context, and then I'm going to give the floor to Antonio and Marcelo, who will be our speakers. The challenge in health has always been key to the life of the population. All public opinion surveys show this. And this importance of the health system was made even clearer by the pandemic. This became a central topic in the life of our population. In the last decades, Brazil had organized itself to face this challenge. We have a national health system, and I say a national system because, in fact, we have three subsystems that live together in tandem. We have SUS, which is the public health system. We have what we call the supplementary or additional health system that cares for 48 million people. And we have the direct payment system. That's where citizens go to a drugstore, to a health clinic, and they pay for their services, whether they are dental services, medical services. That's when the citizen hires these services directly from the provider. And the topic today is how to increase access. From a constitutional and legal perspective, there are no barriers or no boundaries because our system intends to be universal. There's no discrimination. Men, women, the elderly, young people, rich, wealthy, everyone is entitled to have access to this system. But of course, in real life, things are different because there is a severe bottleneck in the system because there's not enough resources. Of course, our constitution ensures access, but we face severe problems in terms of the quality of services, long waiting lines, and the organization of the service, of the flow of services. And although the SUS, the system in Brazil, is a winning experience, it has existed for 33 years. It was established by the 1988 Constitution, but we still face many bottlenecks and difficulties, most of them connected to the lack of finance. Brazil has $350 per inhabitant per year to provide all the services. You know, that means from vaccines to organ transplants, heart surgery, anything is involved, but there's not enough money. On the other hand, we have a system that serves 48 million people. And there is an income issue in what we call the supplementary health system, private health plans. And throughout Dilma Rousseff's administration, we faced a problem. We had 51 million users, and due to the economic crisis, unemployment, this figure went down to 47%. And in 2020, we recovered 1 million new people that acquired a health plan, and we are right now at 48 million. But the barrier in this case is connected to income. When we think about the price of health insurance plans, or when the economy is undergoing a recession or a slowdown period, an important part of the lower middle class has to leave the private pension plan system and move to the public system. There's another discussion that's at the table of the Congress, the Brazilian Congress, which is to create new health plans, private plans, at more accessible prices that have outpatient units and also secondary services, which will allow to have a certain level of access for a larger part of our population. That's what we want to discuss this morning. So now I want to give the floor to Antonio so that you can begin your presentation.
I want to thank the FIS initiative for the invitation, as well as Abramge. And as a manager in this segment since 1990 or 1992, we've been monitoring for a while now and fighting for the segment. The subject is very important for the segment, the democratization of access to health. And we want to have a discussion at the end of the presentation, so we'll quickly cover a few situations, models, and considerations about the subject so that at the end we can have a discussion. As Dr. Marcos said, currently the universe of healthcare plan users has grown in Brazil with around 48 million users now. This is from a total population of 213 million residents in Brazil. And what we see is that we can grow by 77% without going into details of economic profile or purchasing power. We know that Brazil is now currently going through an economic crisis that tends to get worse moving forward. But when we look at these numbers, we also see them as opportunities and as a huge challenge for the management of products that can democratize access to health. Talking about the association, what we have on behalf of Abramge, Abramge is an association with around 150 operators with approximately 16 million customers. And it is within that universe that we have small, mid, and large-sized operators that are present throughout the country. So from north to south, east to west, we are present nationwide, and that has to be respected. But how can we democratize access? And if we look at the operators, and if we think about models they can adopt to improve access, one first aspect that operators use to try to improve access are the management models. Operators, as service providers, need to constantly try to improve their management model. So what does that management model mean? A management model involves every area in operations, ranging from human resources, financial resources, material resources. It involves assistance, operations. Operators are trying to constantly improve these models with increasingly modern techniques to provide better services and to provide better and improved access. Another pillar to improve access to health is technology. Technology has improved and has been constantly improving access on the part of the population. One such example from the last year is the remote medical visits or teleconsultations. And this is yet another access enhancing tool, another technology. And with the health techs, we're able to see some very interesting alternatives is the unified medical history for our patients. And that is an access related problem because for users that go into a medical office, whether it is a private office or an outpatient office, wherever, that patient needs to be monitored throughout their treatment, throughout their entire evolution, whether it is a surgical patient or outpatient or any level of medical care. So technology gives us alternatives to actually provide that. This certainly improves the cost outcome ratio. And of course, just as with every technology, there's a negative side to it. If it's not well analyzed in terms of impact and cost, new technologies currently, if they're not really well used when it comes to regulation, they can cause a very big problem in terms of the financial balance of the healthcare system. And instead of improving access, it can make it even more closed. Another interesting aspect when it comes to democratization, and Dr. Marcus talked about that, is that we now have a certain difficulty in terms of the accessibility of healthcare plans. One example that I like to use is the example of cities with a small level of capillarity, cities with 50 or 60,000 residents with a good hospital or good infrastructure, with no emergency services, whether it is secondary or tertiary. When you have a global coverage plan, you often increase costs and render the plan unfeasible. So a new product opportunity or a product with a capillarity that's adequate for that type of reality, in my opinion, will increase the access on the part of that population without access to such product now. And one last item, and we've been discussing that for many years now. The market's become mature in that regard. It is a revision of the compensation model. We have to stop and look at the fit for service. We have to look at a system based on outcome, based on results, and based on really changing this outcome, because the fit for service is a very difficult tool to manage the system. And it's also important, as Marcos said, concerning the public health system and universal healthcare access. When it comes to that, we have to think about an item that is very dear to my heart. We have a situation where the more supplemental medicine is able to increase it in its number of lives in a structured and well designed way, those users will come to the supplemental system, and the resources used by the public health system will be better managed and better offered to those that have no conditions to adhere to the system. So that's important for the system. We are improving as a whole of the three pillars that Marcus mentioned, the private, the public. So I want to leave you with these comments, and now I'll give the floor back to Marcus. And I want to let you know that I'm available to discuss my comments. Thank you. Thank you, Antonio. And now we'll listen to Marcelo and his comments about expanding access and making it more democratic. Marcelo, over to you. Good morning, everyone. Good morning, Antonio, longtime partners. Good morning, Marcus. It's a pleasure to meet you officially. And I'd like to thank Abramge for the invitation and FIS as well. I'll quickly introduce myself. I'm a CEO and founder of a healthcare operator in the south of Brazil. And I'm an activist in this segment. I want to congratulate Justo, and we've been together in that for over 20 years. I founded the operator, and I've been working in this operator with for over 25 years. When I received the invitation, I must confess that I felt very comfortable to talk about the subject because we're one of the few states of Brazil with a good distribution of the outpatient plan, and maybe due to the characteristics of our companies, and maybe due to trade union agreements that provided that the outpatient care is a minimal benefit, and maybe that's why we have this better distribution. And picking up on what Justo said, to organize our ideas, there are two very strong lines that we have to work on when it comes to democratization. One is the efficiency of the system, and using telemedicine to bring the healthcare plans inland to small cities, because with the telemedicine, you can reach certain areas that it will probably be harder to reach with physical in-person services. We have several initiatives in parallel in Brazil of operators that are trying to integrate the medical history of patients with the accredited network. And that's a challenge, having this unified medical history. Access management, efficient services, offering the right services to the right people in the right location. So that's also a huge challenge for the healthcare system. Communicating and informing people. Health education is a key aspect of the health system, and the technology that's supporting all that. I think that all is within the scope of what operators have to improve. I also hear people talk about a product modulation, and I think this is another line we have to follow and think about on other opportunities. I've questioned that. And now we have an outpatient plan that's regulated with a set of coverages, which is in practice a more accessible health product. I think there may be small details in that product that if we were able to engage the regulators, and of course they have their own assumptions that have to be respected, but if we were able to promote this discussion to show that if we change the rules of urgency, emergency, the first 12 hours that sometimes lead to legal challenges, I think that it generates assistance and its availability, questions related to assistance and its availability. And sometimes people do not have the sponsors to give continuity to their care. So I think that this is mostly related to the healthcare aspect of it rather than the legal aspect of it. I think we already have products to generate better access to health, and maybe by making small adjustments to this product, I could give you the examples of urgency, emergency care, and also the oncological treatments, because the cost of next generation drugs really has a huge impact on the outpatient setting. So I would highlight these two adjustments that we have to focus on. I think by making small adjustments, we would have a product with a good level of price and access to a much larger population than what we currently have. A product that could compete with discount cards. When they give you a discount, it's almost like a reverse co-participation or co-payment. So my question is it really that complex? Making small adjustments to the outpatient setting, maybe in the hospital setting, this discussion is a bit different, or a bit more complex. But if we chose 3, 4, 5 different types of coverage to bring into the discussion, we could have a hospital product that is significant and relevant. And I'm not saying, who am I to say that this has to be maintained or eliminated? But for the people that are able to have a more complete product, that already works. And we have products with co-payment that with we somehow, the legislation has already given us that and brought that into the game. So why not make small changes and create a second line of outpatient products and a second line of hospital products? I also think that creating too many lines would not be good for consumers, because it could create segregations. I think that with the specific segregation that I'm proposing is related to extremely rare, frequent, and extremely high cost items. And maybe we should do a specific work related to that and remove from the public system maybe 5, 10, or 15 million people in 5 years' time. But then you could ask, well, are we going to be bringing transplantation and next generation oncology into the public system? Yes, maybe, but maybe dental services. How much are we going to remove from that system? Because I am an advocate for the unified health system. I studied it at university. I think it works in some locations more than in others. We have a system that generally works, but its biggest challenge is to give access to 150 million people. What I see in the regions where I work is that the public health system works for high complexity surgery. It works as a counter reference, even in the outpatient setting. But the public health system could bring about more difficulties for Brazilians that want to have a visit with the specialist and an echocardiogram, and sometimes it's 3 or 4 months before they're able to do the exam. And when the time comes for them to do the exam, they either no longer need it or they need something different. So to try to give my contribution, I could say that it's 2 major lines. For one, maybe with our leaders, Abramge has a very active president, Renato, and other extremely strong and solid entities, and the Brazilian health system, hospitals as well, that can help organize this system, private hospitals. And there are so many other entities that could and are working in that regard. I know that. So there's this first line, which is a line of trying to create a higher efficiency in the system and more access, and for operators to become more competitive and more efficient, generating the best product at the lowest possible prices and the best access level. But there's also legal aspects and a more macro aspects, discussions that are huge, to make health more accessible, and that really do not involve any operators, and whose decision so would have an irreversible impact on the health operators, because in the long run it will significantly increase the fees, and that will restrict access, making healthcare access infinite is not the same thing as saying that health is infinite. What would be the cost of managing infinite health? You don't have to be a data scientist to come to the conclusion that this infinite access will become higher fees in the future. And then you'll start a spiral towards higher costs, less access, less coverage. And with that, you have more people inflating the public health system. I think I've covered my 10 minutes. Thank you. And I'll be available to continue the discussion. Thank you, Marcelo. So now let's wait for questions. I think our presenter will probably send us questions. And I'd also like to provoke interactions between Antonio and Marcelo while we wait for questions. Something that Marcelo said very well: we have to have predictability. You cannot have an open product. One of the central problems in an outpatient product is exactly the problem that Marcelo mentioned, which is the urgency, emergency, and that has a connection with the tertiary sector, and that introduces unpredictability into the, you know how it starts, you don't know how it ends. And having a clearer definition of products and having more transparency for users, for consumers, and clearly defining a product with primary and secondary care and all of the specialties and the exams, which is clearly separate from the hospital segment, including high complexity and emergency and urgency. With that, you could benefit millions of Brazilians with a plan, and relieving the public health system. The cost for the public health system per user is 1,500 reais. So these 13 million that abandoned supplemental health and came to the public health system cost 4.5 billion reais per year, placing a burden on the system. So Antonio, maybe you could comment on what Marcelo said: expanding products. There's a special committee in the lower house. The ANS has been discussing that. So with small changes, we could be successful. What's your opinion? I'm in favor of this expansion. And I think that the example I gave you of a small hospital in small cities of Brazil with lower capillarity, that's one such example. The example I could give you is the Santa Casas. We have lots of such hospitals across Brazil, and that's a good alternative for the population. And improving capillarity in the smaller cities, if you do that, we could have better resources that could be very important in terms of providing better quality, more adequate services. And of course, that will not work if there's no use changing the product and making everything very clear. And if it is being interpreted the way they have to be interpreted, they could say no. But it can't be done. So I agree with Marcelo, but the product and its current adoption in the way it is now, it is imperfect. And for the population to be able to access I'm sorry, he's breaking up. There's no high complexity transplants, but we have other services. Sorry, he's breaking up. I agree with Marcelo. Marcelo, one criticism, I was secretary for 8 years in Minas Gerais, and the transplant queue itself, people with health insurance plans ended up having a privilege in the line, which is absolutely controlled and regulated. But when there was a compatible organ, people with supplemental health and with up-to-date exams would have a benefit, because people from the public healthcare system, their exams were outdated. And many people think that it's either all or nothing. You either integrate everything, or segmenting and offering a simpler product that's more accessible to more Brazilians. You would be denying it, and then they would have to rely on the public health system. But the early diagnosis of breast cancer and prostate cancer, it makes a difference. So having specialists and going into the queue earlier on makes sense. But there's this criticism that many politicians and many healthcare specialists, they'll say that either you have to offer everything through a healthcare plan, or nothing, because you cannot offer something that's segmented. How do you see that? Well, that was deep. Just as with everything in life, there's ideologies involved. I disagree due to pragmatic and logical reasons. I think that one thing that should be the basis of this discussion is that private healthcare should not be mistaken for collective healthcare. I think what differentiates this discussion is that we have to understand that collective health means that we have to give as much as we can to everybody. And then there's these aspects related to the universal aspect of the unified health system and a private healthcare. If we consider that that's often quite expensive, I think that should be separate, but I acknowledge that that is a highly ideological discussion and healthcare specialists, but I don't agree. I think that the number of people that we would add into the private system with those people that would remain in the public system, we would be able to give them many more medical visits and services. So the private system customer could also use some public services, but isn't that the way it works? If my customer, for any given reason, had access to a transplantation through the clinic's hospital, and he undergoes a transplantation, it's the operator that's going to be charged. So the public system is already used, whether you have or not a healthcare plan. It's like that, but then the operator will compensate, but that's a financial discussion. We were not influenced by the all or nothing discussion. So that is my opinion, but I do recognize that it is an extremely complex situation that's highly influenced by ideological aspects. In February 2018, I was a congressman and I organized a parliamentary mission with another 5 representatives to learn more about the Portuguese and Spanish systems. We went to Madrid and we went to Lisbon, and we visited primary care units, hospitals, outpatient clinics, and we also visited the parliaments, the Spanish and Portuguese health committees. And when we talked about judicialization, the Portuguese and Spanish would look at our faces and go, oh, what do you mean? It's something that they can't understand, this example-based and fee-based list. It is a decree that defines what the system is going to offer. And that is how it happens in Canada, France, the UK. That's how they work over there. So this is a Brazilian specificity in the public health system. There is no list of procedures. It's an open thing. So it gets mistaken for this interpretation, everything for everyone. And on the other hand, in supplemental health, there is a list, but we're left with the discussion of whether it is just example-based. If you do not define the frontiers, how can you offer that to society and to users? So we have really to achieve a greater transparency so that consumers are able to tell exactly what they're purchasing. And there are some controversies. There have been some controversies in the past because the relationship of users and healthcare plans is contract-based. The relationship of citizens and the public health system is constitutional. It's citizens' rights. It's not consumers' rights. If you purchase a private healthcare plan, you're still Brazilian and still entitled to using the public health system. And the rule that the Supreme Court used was that the healthcare expenses could be deducted from your tax declaration. So that was the base of the discussion. So I think that we have a long way forward, and we've reached the end of our discussion. Antonio and Marcelo, would like for you to say a few closing words. We have a commission with over 240 bills about supplemental health in the Congress. And we have this commission trying to synthesize and come up with a new regulatory framework, which is, and the report is about to be published. But what are the lines thinking about this government and the end of 2021 and 22? What are the essential transformations that ANS and the Congress and the Ministry of Health should produce in this period, in the short term, talking about 2021 and 2022? Antonio. Well, to answer your question, the market, in order to improve access, also requires better management and better practices, and needs to improve the way it manages resources. It also has to look into to look at the operator as a access path. And if we talk about the regulatory and legal perspectives, and reinforcing what Marcelo said, the legal framework needs to be made very clear. And with the support of the legislative. You mentioned that we just went through a review of many projects which are under discussion, and that has to be made clear. We know that there are representatives that want to put everything in the law. If that occurs, it won't make sense. It would be impossible to manage supplemental medicine. So in my opinion, what we have to revise is that we have to make the legal framework clear, what it covers and what is covered by the healthcare plans, and that has to be respected by the judiciary. We also need to do some work with the judiciary, and they have to understand, like you said, that we are based on a contract with liabilities and duties and rights. So when it comes to the chamber and the Senate, we have to make that clear. In terms of the federal aspect and the executive, especially, our minister really needs to understand this dissociation between supplemental medicine and public medicine and our importance in the industry. It's 48 million people that are served by supplemental medicine currently. Marcelo. Well, I think we have exceeded our allocated time. So I'd like to thank you for the participation and say that I'm available to become an advocate for the system. I really like what I do. And I would very quickly say that we have to regulate telemedicine and clarify that the list of services is being revised, and if possible, also bring more flexibility into the system, and that the judiciary also listens to the requests of society. I think this will give us a lot of work to do in 2022. That's what I wanted. Thank you very much. That's a great summary. Our discussion was highly productive. I'd like to thank Abramge and the FIS initiative, and I'd also like to thank everyone who's watching us from home, watching this discussion about the bottlenecks and opportunities for expanding access to health.